Hello and welcome. We're discussing innovation from the pandemic, from video appointments to electronic consent. The hashtag for this event is PetIFP. This discussion has been made possible thanks to the kind support of the Scottish Government. I'm Ciara Norcross, Director of PET, and I will be chairing the discussion. Casting our minds back and remembering early 2020 when the coronavirus pandemic struck, the incipient panic when there was the announcement that we had to work from home. I'll never forget seeing dozens of office workers carrying their computers and monitors down the street in central London. It was like watching a scene from a disaster movie, except there was no man in the obligatory white vest strutting down the street ready to save me or anyone else. We didn't really know what was coming. And that first lockdown was frightening. But for fertility patients, the background fear which we all felt was compounded and amplified really by the compulsory closure of fertility clinics with no indication as to when they would reopen. Now, thankfully, fertility clinics were allowed to reopen a few months later. So in May 2020, Sally Cheshire, who was at the time the chair of the Human Fertilisation and Embryology Authority, told BioNews, "I am pleased that the HFEA has agreed that fertility clinics can apply to reopen from 11th of May. Our priority throughout the pandemic has been to consider how treatment could resume quickly and safely for as many patients as possible. And our clear plan sets out how clinics can treat and care for patients safely during the continuing COVID-19 pandemic. I know that the closure of clinics has been extremely distressing for patients, and this will be good news for those wanting to resume treatments and have the opportunity to try for a much longed for family." You can read that full article for a reminder of what happened, because it's easy to sort of forget and move on in some ways in BioNews. But I think it's fair to say that it was a far from straightforward process for clinics, particularly those in the NHS, to have to introduce lots of new protocols to put in place to protect patients and staff from the virus. And in the NHS in particular, staff may have been redeployed to other departments where help was needed, but also just the sort of the logistics of getting in and out of the clinic in those days was actually quite complicated. But the disruption caused by the pandemic meant that there was the opportunity to innovate and to try new ways of doing things. And I think the old saying that necessity is the mother of invention could be applied here, because things, people had to try and do new things to make things work again. And tonight's panel are fertility professionals who are at the sharp end of the implementation of some of these changes. So we have for you a clinical research fellow, a specialist nurse, 2 fertility counsellors, a clinical embryologist, and a quality manager, who will all discuss how they had to do in their clinics, what they've learned from the pandemic, and perhaps whether there's any scope that they can think of for further innovation. So we have Dr. Ashleigh Holt-Kentwell, Ciara Heatherwick, Lesley Benzie and Alison Elliot, George Hughes, and Dave Wales. And our first speaker this evening is Dr. Ashleigh Holt-Kentwell. Ashleigh is a clinical research fellow at Aberdeen Fertility Centre. She was previously a registrar in obstetrics and gynecology. Over to you now, Ashleigh.
Good evening, everyone. So today I'm going to be speaking on electronic consents in the fertility clinic. And firstly, I'll give some background as to why and when we're using consent forms in the fertility clinic. then talk a bit about the benefits and the challenges that we've experienced with implementing electronic consent forms. And then I thought it would be good to apply this in a clinical situation. So how does that look from the patient perspective in terms of the pathway and where the consents fit in? And then I will show you a few screenshots from what the consent platform actually looks like. So consent forms, they are a requirement by law for patients to give written informed consent before their fertility treatment starts. And consents are in place to ensure that a patient or couple's sperm, eggs, and embryos or gametes are used and stored in the way that they intend. If a couple are not married or in a civil partnership, then giving consent to who will be the child's legal parent is vital. Problems with legal parenthood consent have led to couples having to go to court after their child is born so that legal parenthood can be declared. So this is a slide just giving an example of some of the types of consent forms. So they range from detailing storage duration, consenting to a particular type of treatment, right through to how their personal information can be used, and they're all as important as each other. So electronic consent forms, the HFEA updated the code of practice to include guidelines for the safe and effective use of electronic signatures for recording and storing informed consent. And they did that in September 2019, which was very timely just ahead of the COVID pandemic. Before this, the HFEA, they'd only addressed paper-based consenting for use in completing the mandatory HFEA forms. And I believe here in Aberdeen, this was before I was in post, but I believe that in Aberdeen, we started using consent forms in the fertility clinic in December 2020. So what about the benefits and the challenges? Well, in the fertility clinic here, we found that patients are really pleased that their consent forms they can access from anywhere and on multiple potential devices. So that could be on their phone, on a laptop or a desktop computer. And we do suggest a preference actually to complete it on a laptop or a desktop, and I'll go into why that's the case. And really this fits in with the paperless ethos that I think many clinics have now. Certainly in NHS Grampian, we have an electronic clinical note system as well. So these forms, once they've been completed and confirmed that everything's correct and in place, they can actually be exported easily straight into the patient's notes in PDF format. As part of the consent platform, there is quality assurance. So on some of the forms, the system will pick up if there are mismatches, for example, in partners' answers, where it's quite important that, for example, embryo use and training, it's important that the couple's answers do match, and the system would show that up as an error for you to review. The forms can also be individualized to the couple, and that can include in-house forms. So for example, self-funded patients, they can be sent a costed treatment plan that's individualized to the treatment that they're receiving. Within the platform as well, there are two helpful sections. There is a section where you can message a patient directly to their phone, and often we use that for reminding patients to fill out their forms either before a specific appointment or actually before their treatment starting. The notes section is also useful to make notes, for example, where you've discussed a particular mismatch potentially with a couple, and if they're happy to default to the option of not using embryos, for example, in training, then that can be noted there. And everyone that reviews that couple's consents can see that note section. And ultimately, electronic consent forms, they're really facilitating video consultations because we don't have to see couples in person in the clinic to be going through their consent forms. So there have been challenges, and it was a steep learning curve for everyone involved, I think for clinicians, all members of fertility clinic staff, and also for patients. Consent forms, they are only available in English at the moment, so we have pretty uncommon occurrences where we may have to use paper consent forms because we need an interpreter, and that would be an in-person appointment. We have found that patients completing consent forms on their phone, it does increase errors if the tick boxes don't quite line up. And some of the errors aren't actually picked up by the consent platform. It does still require, obviously, you to go through manually and check that everything is in place and has been completed correctly. The consent forms in paper format or electronic, some of them are quite lengthy and time consuming. There are videos on the consent platform for patients to review, which are also time consuming, but the feedback we get is that they're useful. And then finally, if there are errors on consent forms, the whole form has to be reissued to the patient. And if it's a joint form, then both partners need to refill that form, even if only one of them has made an error. So that can increase the time spent on these. But there's a working group for these consent forms. Changes have already been made, and that's to reduce the errors. So I thought I'd give you an idea of the patient pathway. So once a patient or a couple have been added to a waiting list for treatment, that's when they'd be sent their electronic consent forms by the admin team, which would be individualised to them. They would then, here in Aberdeen, we have a patient information evening that they would attend, where the consents are described in more detail and how to complete them. Their consent forms would then be filled out by the patient, and a video appointment with a doctor would then be arranged to review that couple's consent forms and discuss the consents with them, complete any ID checks, and errors could be picked up at that point where consents might need to be reissued. After that, there would be a nurse appointment where their treatment is scheduled and their consents are confirmed as complete. And then the final check would be by the lab team just prior to treatment starting. And their consent forms would either be exported at that stage if they had not been exported already. And then their treatment would start. So here you can see how the text message would come through. So what they would get is a message with a link to the platform, which we often say to type actually into a computer or a laptop rather than use their phone. And they've got a unique key phrase to this multi-factor authentication login. And we advise couples to complete their consent forms together. Here is the front screen of the consent platform. So you can see that you can see the type of treatment the couple are having, the funding, and this is where you can check their IDs. And then along here, you've got the different tabs for the different parts of the platform. So scrolling down, this is how it would look. These are the videos for the patient to review, and this would go green once they've completed that video module. And then further down, that's the actual consent forms that you'd be able to click into that would show as completed with a date and time. This is the notes section, so a note could be typed in from any fertility clinic staff accessing that couple's consents for everyone to review. And this is where you can send messages. So you can type a message in here and you can send it to either patient. And then down at the bottom, it's really easy to export forms once they've been completed, and that would go directly into the patient's notes. So that's down on the bottom right. So in summary, I think electronic consent forms have been a timely change given the COVID pandemic, and I think overall, certainly in Aberdeen, we feel that the benefits are outweighing the negatives after what was quite an initial steep learning curve. And there probably are still changes to be made, and it's brilliant that there's a working group working on that. Thank you very much.
Thank you very much, Ashleigh. It's absolutely fascinating for me to see behind the consent platform, because it's something I've not seen before, and to see how that then sort of goes through to patients. So thank you very much for that very clear insight into the process. So next this evening we have Ciara Heatherwick, and Ciara is a specialist nurse and pre-implantation genetic testing coordinator at Glasgow Royal Infirmary's Assisted Conception Service. So Ciara, over to you now.
I just share the screen. Hopefully it'll work. There we go. Thank you for asking me to speak this evening about how the changes brought about by the pandemic have affected the nursing practice in our unit. I do think some of the changes would have evolved over time, but the pandemic forced our practice to change, and in some cases before we were really ready or prepared. I'm going to speak about the kind of main changes and how they have affected our practice and how the nurses feel about those changes. One of the main things that we introduced was e-consents, and although e-consents had been about before COVID, they hadn't been implemented in our unit properly. The consent appointments in our clinic are carried out by the nurses, and when I asked them about e-consents and how they felt, the feedback was consistent. One of the main benefits of e-consents is that patients are all given the same information. However, some patients aren't fully engaging with the content and are coming for appointments still a bit unsure of the process. Previously, the nurses provided the patients with the information, whereas now the patients need to access that information independently. Another benefit is that patients have access to the consent forms remotely. We take patients from all over Scotland, from the islands right down to the north of England. So, and some patients might be in the forces or work on the rigs. So for them, being able to complete the consent forms remotely and cut out an appointment to the clinic is a benefit for them. However, we do have a percentage of patients every week who, by the consent appointment, still haven't even logged on to the portal or have only partly completed the consent forms. And for some of these patients, we do need to cancel their appointment. So that does kind of wastes their time, it delays their treatment starting, and it wastes the time and resources set aside for that appointment, and ultimately then we have to rearrange another appointment for them. Some of the appointments they give is that they didn't realise the partner had to log on separately, that they couldn't get logged onto the portal, or that they had forgotten. So for this reason, some of the nurses do prefer paper consents, as they were more likely to be read and completed by the appointment. Another perceived benefit of the e-consents was that it would save the nursing staff time, because patients would be able to access the information and complete the consent forms before their appointment. However, the time that has been saved with that is now taken up with other consent-related issues, such as reissuing forms with mistakes, having to recheck the forms, checking the AMHs and issuing the treatment. So from a time-saving perspective, this benefit hasn't really been seen. It has also increased the number of phone calls to the nurses. And just for example, in one day out of the 60 voicemails the nurses received, 10% of these voicemails were about problems with e-consents. So most of the nurses, even those who preferred e-consents, felt the paper consents were easier to deal with when a mistake was made. It could be corrected there and then, rather than having to reissue the whole form and check it again. And this can be quite frustrating for patients as well as staff. Although everyone did agree that the main benefit was the reduction in the amount of paper being used. So overall, nurses wouldn't go back to paper consents, but we feel that the platform could maybe be improved, especially for patients who their mobile phone is their only IT and internet access. And I'm looking forward to hearing what George has got to say, because I was wondering if anyone's looked at the health literacy of fertility patients and how effective that online content is at providing information. So the next change I'm going to talk about is virtual appointments, and I probably should have started with that because that was the first change that we made. When we were able to open the clinic again, we were able to start offering virtual appointments for appointments where it was just information given and completing consents. And it meant patients didn't have to travel long distances It minimised the time they needed off work, and they could stay in the comfort of their own home, as well as reducing the risk of infection to staff and patients. At the beginning, though, we didn't have one platform to use for virtual appointments, so we were going between a mixture of Zoom, FaceTime, Teams and Attend Anywhere, which caused a lot of problems for both the staff using the equipment and the patients. And until that point, some people had never used any of these platforms and were sort of expected to be able to set up and attend appointments, sometimes with internet connection that was less than ideal. So it very much depended on how IT literate both patients and staff were as to how successful these appointments were. A couple of years ago, we decided that everyone was going to use the Attend Anywhere platform, where patients are given written information on how to access the waiting room, and they should be there when the nurse logs on, ready to start the appointment. Previously, some of the time that was allocated for the appointment was spent just trying to log on to the appointment. So that's made things a lot more streamlined and user-friendly. However, all of the nurses asked would still prefer to go back to face-to-face appointments. And some of the reasons given were that the appointment quality could be affected if the Wi-Fi was poor, and there were fewer distractions in the clinic if you're doing a virtual appointment. Sometimes you've got things like the dog barking or the cat walking across the screen, or on one occasion a couple joined the call while they were still in bed, and another couple joined the call while they were in a restaurant. So those calls were rearranged. I think another benefit of that was brought about by the pandemic was access to online learning. Being able to access study days online, webinars, a lot of webinars have been brought about, and being able to access MDTs remotely as well has really kind of opened up access to studying and meeting other people. And I know some study days do benefit from a in-person approach, being able to not have the cost to the NHS of travel, accommodation, time away from work has meant that more people have been able to get study time and attend these online study sessions. So the things that we changed because of COVID that we want to keep are more timely appointments. So before COVID, we didn't have enough time for the appointments, and it ultimately meant a very busy waiting room and patients having to wait over an hour sometimes for their appointment. Whereas when we opened back up again, we increased the appointment times to allow for cleaning of the rooms in between patients and to reduce the amount of people in the waiting room. And that's worked really well. And it also allows a wee bit more flexibility. If a patient needs a wee bit more time in their appointment, it's not going to have as much of an impact on the rest of the list. E-consents, we do like the concept, but we feel the technology could be improved, and we need to try and improve patient engagement with the information that's there, I think. And virtual appointments. So although we all prefer face-to-face appointments, I think it would be really hard to justify going back to face-to-face appointments just for information given because of the benefits to the patients. Some of the changes that we're glad are gone are no patient partners being allowed in the unit. That was really horrible for a lot of patients, especially ones who were going through really horrible things like miscarriage diagnosis and getting bad news. Social distancing. So I think when you work in somewhere like our work, it's really important to be able to kind of talk to each other about things that have happened and socialise outside work. So it's really nice being able to share a tea room again and have nights out. And COVID swabs in our clinic, we had to COVID swab everyone who was ready for egg collection. And if they had a positive COVID swab, their egg collection was cancelled. So you can imagine how awful that was for a lot of patients. So I'm glad we don't need to do that anymore. Thank you for listening.
Thank you very much, Ciara. It's a really clear presentation of the impact and the changes and the struggles, and I particularly liked the sort of the weighing up you did of the pros, the pros and cons of some of it. So thank you very much for that. We have two speakers for you next, Lesley Benzie and Alison Elliot. They are both fertility counsellors at Glasgow Royal's Infirmary's fertility counselling service. Lesley has over 28 years experience as a counsellor and psychotherapist. She's BACP and BICA accredited and began work as a fertility counsellor more than 8 years ago at Aberdeen Fertility Centre, and has since 2018 has worked at the Assisted Conception Service in Glasgow. Alison has a master's in public health, and she's a trained counsellor and has accrued 20 years experience, initially working in sexual health and complex trauma before she went on to specialise in fertility counselling. She's an accredited member of BICA and runs training courses for them and offers clinical supervision to fertility counsellors. So they're doing a joint presentation, and Lesley will be starting us off.
So I'm going to talk a little bit about what the counselling service to the assisted conception service looked like prior to COVID-19. So basically there's two of us that job share over the week. The counselling service was based in a separate building to the assisted conception, the rest of the team. We had no admin support for the counselling service from ACS side, but we have some goodwill admin, as in taking phone calls and letting us know that patients have arrived from social work that were in the same building as us. We were a completely paper-based admin system, so all our notes were kept on paper, all referrals received by paper, all our evaluation audit material was done on paper. And at that point, we mostly did face-to-face counselling. We had literally a few months before started using NHS Attend Anywhere for a few patients who were living, like Ciara said, in the islands and further away. But we were pretty inexperienced at that point. And I suppose what I would say is that there's lots of reasons to hate COVID, but in terms of the counselling service as it was, it did force some changes that have been quite beneficial for the counselling service. So yeah, as I was saying, a lot of all of our referrals from the multidisciplinary team in the private part of the ACS was by letter via internal mail, often arriving weeks within. Never understood why, but sometimes it would be weeks before we got a referral, and often basic information was missing, like a mobile number. And we, because we don't have admin support, have to do all our own, phoning patients and getting them booked in at that time. Well, we still do actually, but it's a bit easier. Self-referrals were by phone, and they were somewhat quicker, but often they were voicemails, because if you're running a busy clinic, you're not able to answer the phone. So we would be often responding to voicemails, and which could result in a bit of ping pong back and forth, them leaving message for us, we leaving message for them. And at that time also we took referrals and networked with other organisations, as long as the patients had been or were patients of the ACS. So the face-to-face was in, face-to-face counselling appointments was pretty inconvenient for those living far away. And obviously, if anybody's going through treatment, they have lots of appointments. So often, obviously, their medical appointments took priority over psychological appointments. So sometimes people just found it hard to fit in counselling in amongst everything else. As I mentioned, we just began to use video counselling at that time. When we saw patients at that time, often their first appointment was completing lots of the paperwork because we didn't really have other ways of dealing with it at that time. All our notes and any information from patients was stored in locked filing cabinets. So we've got lots of filing cabinets from before, which we don't have anymore. And things like collation of statistics and questionnaires for patients was all paper-based and all collated by us because we had no admin support. So changes to counselling service was pretty immediate. We went to working from home. We went to totally digitally based admin systems. I mean, it took us a bit of time to implement those, but we went from lots of paper to virtually no paper, and all our counselling was done online through NHS Attend Anywhere. So some of the things that we had to do to implement that in a different way was that we issued a new referral form that detailed all of the information that we needed on it, and basically did a pathway for the staff about how to, make it easy for them to get an email us. And I know that sounds ridiculous, but some people put up quite a lot of resistance to that initial change. But now it runs really smoothly. Our email addresses and the social work admin number went online so that patients could email us directly or leave a message with social work admin. And we weren't having to do lots of this voicemails back and forth. All the pre-therapy paperwork, details about them, because we worked in a different building and then we went to working from home, we didn't have access to patient medical files, so we were able to email them out forms and our confidentiality agreements and stuff, and that was all completed and emailed back to us. And by that time we had managed to get a digital case notes folder, and we could save that directly into their file on the secure database. Annual audit, all the patient questionnaires now on Microsoft Forms, and that collates information automatically as we send a link that by email, and that collates it automatically. And now all our data is quantitative information is on Excel spreadsheet. And basically online video counselling, because we were using only the one system, NHS Attend Anywhere, it's really easy to use, and patients get good information about how to use it. So for the most part, it's easy to use. And I'm going to hand you over to Alison now.
Thank you. So in general, online video counselling support was vastly improved access to counselling, and improved referral processes enabled a quicker turnaround, and there was no big gaps between perhaps a patient talking to one of the clinicians saying, I would like counselling, and there being a large delay for us to get back to them. Initially, clients were distressed because fertility treatment had been stopped, and when all clinics shut down, the perception was that we would be very, very busy, but it wasn't until the clinics started opening up again and started having to prioritise which patients that they were going to see that's when we became extremely busy, people feeling why them and not me, feeling a real sense of injustice. So our client numbers doubled. Part of that was also not being able to meet up with family and friends, maybe not necessarily to talk about fertility treatment, but just to be able to talk about perhaps other stressful things that were happening in their life. So at the moment, when we see clients, we might see them fortnightly, or it might be more ad hoc, depending on whether they're going through treatment or whether they're anxious about starting. But during COVID, we were seeing people much more regularly. Quite often, it would be us that they were seeing on a weekly basis to be able to talk about some of the stressful situations. A lot of people were also working from home, so online counselling became more accessible. Their companies were, as long as they did the work, it didn't matter that they perhaps took an hour out to have a counselling session. It also meant that partners could be in different spaces, known donors could be in different spaces, surrogates, interpreters could all be in different spaces, but we could all meet together for that counselling session on Attend Anywhere. So it was convenient and flexible for clients. There was no or reduced time travel, time costs in general, specifically if somebody was living in a remote area. The comfort of home makes it much less stressful. I remember seeing a client who I'd seen in person, and she'd always been quite anxious. And then I saw her when we were both working online, and she was so much more comfortable and so much more relaxed. And when I explored and talked it through with her, she said, well, usually I'm racing from work, I'm racing to the hospital. The hospital's in the city centre. It's at peak times. She's then trying to find a parking space. And then she's trying to find me in an obscure admin building. I'm on the 4th floor, and sometimes the lift doesn't work. So the client was already very anxious before she even entered the room to start talking about her experience of fertility treatment. It's also good for privacy. Some clients reluctant to go back to come into the fertility clinic. So for example, maybe they associate it with bad news, maybe they finished treatment but are still requiring counselling support, and they don't want to go back to clinic. Attend Anywhere is a very secure system, so both clients and counsellors feel confident about using that. And also much improved admin processes means that we are able to offer additional sessions, greater availability, and that leads to greater client access. Online working isn't always good. Ciara's already pointed out. We've all worked on different platforms. Clients can be easily distracted by pets, someone at the door, it's the postman. We try to minimise that by sending out a leaflet beforehand that talks about online etiquette to try and treat it in a professional way, as they would if they're coming to meet us in the office. So that means it's not okay to wear pyjamas, it's not okay to be able to have a counselling session from your bed. Again, Ciara pointed out, sometimes the quality of audiovisual is very dependent on the client's Wi-Fi. I can control my Wi-Fi from at home, I can control it when I'm at the hospital, but I can't control my patient's audio or visual. And I think, Sarah, just what you were saying, Sarah, what you were saying right at the beginning is that almost it needs a pandemic for innovations to happen. When we first started working with Attend Anywhere, which was the July before the pandemic, it was very pixelated. The audio was really bad. It was a means to an end to the clients who lived in the Highlands and Islands or down in Dumfries and Galloway. We also don't have control over our clients' privacy or security and their location. So there's been times that perhaps I've been talking to my client thinking it's perfectly secure, and then somebody else will walk into the room, or they'll start chatting to somebody else who's present in the room that I've been unaware of. And we also need to consider safeguarding and welfare of the child risk. So thinking if we feel that somebody's at risk, then we would want to see them in person. Client responses to working online have been really positive. One client just talked about how she had to take lots of time off to go to medical appointments, how it was interfering with work. That was causing an additional stressor. So it was actually quite good to have them online and minimise the time off work. Other themes of feedback we got from clients was just how accessible, how flexible, and how quickly we were able to offer them a counselling appointment. So where are we now? So at the moment, we're offering a hybrid service. We go into hospital if clients are saying that, yes, they would prefer to have a face-to-face appointment. The majority have asked that we retain the online service because of the flexibility and accessibility. We want to meet the needs of as many clients as possible. So if clients want variety, even we may start with somebody in person. So quite often the client might say, it's quite difficult to start talking about very personal issues. I'd like to meet you in person. We'll see how that goes. And once we start to build that relationship and they feel more comfortable with us, then we can then move to working online. There will be cases where we decide that we want to see them in person. So for example, if it's a particularly complex case, if it's a welfare of the child referral, if it's surrogacy, if it's a known donor, we like to see the interaction between the intended parents and the known donor, or the surrogate and her partner and the intended parents, or again, if there's safeguarding issues, if we're concerned about risk. We now have improved robust procedures in place, including those regarding risk, and much smoother admin processes in general. So thank you.
Thank you very much, Lesley and Alison. It's really interesting to hear about some of your perhaps teething problems at the beginning with the Wi-Fi and all the rest of it. And I have to say that, here at PET, before, we had to change our systems, start doing our events online and getting used to that. And also, just the sort of making sure everyone had the right kit, was quite a challenge at the beginning. So I can certainly relate to some of what you were talking about. Now I can see we've got one question, which is quite unusual for this point in proceedings. So people, just don't forget, you can post your questions in the Q&A box at any point. So have a think and start posting them in there, ready for when we go to Q&A. The next speaker we have this evening is George Hughes. George is the lead clinical embryologist at Ninewells Hospital's Assisted Conception Unit in Dundee. George.
Hi everyone. So I'm going to talk about have online consent forms impacted the likelihood of patients consented to training? And first of all, I'd just like to say thank you to Dr. Morven Dean, who has really done all the work for this and presented previously at Fertility 2023 in Belfast. So I'm just following up for her because she's on maternity leave at the moment. So in previous presentations, we've already touched on the pros and cons of introducing fertility consents online. So in our experience, we've seen a shift at Dundee to online consents. So all patients now are filling out their consents online. And there's positives have come from that. So for patients, it allows completion of consent forms in their own time and space. It reduces the appointments for them also. And also for clinics, we've seen that using online consents allows the standardization of information. It's an efficient way of sharing the information, which is quite a large volume of information at times. And it reduces patient contact time. It's easy to upload consents, make changes with the consents, although in previous presentations that obviously we've talked about the challenges with that as well. It can minimize confidentiality breaches, improve storage capacity, and also lastly, it's a step in the right direction to introducing a paper-light system, which improves sustainability. So our concern as, so I'm a clinical embryologist, and we've got members of staff in the lab that needs to train with material in order to become trained embryologists and andrologists. So we were concerned once these online consents came in that the availability of gametes and embryos for training purposes declined. And we didn't know whether this was due to the online consent forms being introduced or perhaps other factors. So in terms of consent to training, so patients can allow their consent, which means that the gametes and embryos that aren't used or are not suitable for treatment can be used by designated healthcare staff to practice the treatments involved. So this allows ART staff to become appropriately trained, and it allows them to ensure competency to undertake clinical procedures. This can only be achieved, however, with gametes and embryos that are given for training purposes with appropriate consent from the patients. I think it's really important to state at this point that patient decision to consent to gametes and embryos being used for training purposes does not affect patient treatment in any way. So what we looked at is we performed a small audit and to see what the impact of introducing online consents had on patient decision making. So we felt that when we introduced the online consent platform that less patients consented to training with the gametes and embryos. So we first of all, if you can see in the methods there, we started online consents in Dundee in June 2021. So we took a sample of 100 consent forms prior to that, which were in the paper format. And we also took a sample of 100 consent forms which were on online format. At that time, we looked at the male consent to treatment form, which is the MT, and at that time it was version 7. We also looked at the women's consent to treatment and storage form, which was at that time version 9. So we compared online consents completion for MT and WT versus online paper completion of MT and WT. And on the left-hand side of the screen, you can see the information that was present in the MT form and the WT form at that time. And in section 5.1 of each of the forms, it asks patients, do you consent to gametes being used for training purposes? And in section 5.2, it asks, do patients consent to embryos being used for training purposes? So what we found from those from that information gathering is that there was a reduction in the proportion of patients that consented to training with gametes and embryos. And this is highlighted here in table 1. So we saw that for male patients completing the MT, consent to treatment and storage, and female patients completing the WT, consent to treatment and storage. We preliminary results, we applied GraphPad Prism and looked at a two-way analysis to identify a significant decrease in the number of patients that are consented to training. So this was seen for completion of MT forms and completion of WT forms. This was seen across the board. There was no difference between MT and WT completion. So what did we take from those findings? Well, we initially focused on that there's minimal information in the consent forms at that time. So on the left-hand side here, you can see that section 5 is the information there is quite sparse. Of course, we also would speak to patients about this information about how to complete the consent forms. But at that time, we felt that perhaps patients' awareness need to be increased. And of course, that might mean that there become the availability of training of gametes and embryos had declined at that point, which of course had consequences for training and development of staff skills. But it also made us have some concern for patient understanding of the online consents. Was the consent informed? Do patients understand what consent to training means? And we we considered that patients obviously respond to and retain information differently. So we perhaps need to adapt practice in the future to support patients to make sure that it is informed consent. So in 2022, in July 2022, UK legislation changed, and the extension of storage consents for patients with gametes and embryos went beyond 10 years, up to 55 years. So at this point, the HFA implemented new storage regulations, and the MT and WT consent forms were updated. And we thought at this point it'd be very interesting to look at we'd collected data again to see whether there's changed anything. So the consent forms that were distributed at that point from the HFEA had a lot more information in relation to training. So I've mentioned earlier section 5 in the MT and WT form. The HFEA expanded the information in that section within the consent forms. So again, we took another 100 samples, and as you can see here in the screen, the information, sorry, I just need to go back one. So that section 5 changed completely in the MT and WT form. And at this point, the patients are again asked if they consent to their gametes being stored for training purposes and their embryos being stored for training purposes. And an addition from the HFA at this point to the consent forms was that patients can store gametes. Sorry, clinics are able to now store training material, which they can perhaps create a bank of training material for members of staff to use for training. So in terms of storage of gametes, that can be up to 55 years. And in terms of embryos, that can be up to 10 years. So importantly, within the consent forms, there's more information. There was a better explanation of what consent to training means, and it's highlighted in the consent forms that the decision to consent to your sperm and embryos for training purposes does not affect your treatment in any way. So we looked at the new consent forms that were brought into play, and we again looked at another 100 samples in the new version of the MT and WT. And what we noticed, the results were that there was a recovery. So initially we saw that there was a recovery in patients consenting to training using gametes and embryos. But this recovery was not significant. So looking at this screen here, you can see that we initially sampled patients that had completed consents using paper copies, patients that had completed consents online at the same time as the paper. And then we also looked at completion of online consents following the changes in the storage regulations. So overall, at that present time, once the study was concluded, we saw that there was a decline from consent to storage with electronic consents versus paper consents. So just to summarize the presentation, so we observed a reduction in the consent for training purposes after we transitioned to online consent platform at Dundee. This was slightly rescued by the updated MT and WT forms, which came into force in July 2022. And what we also took on board from the change in storage regulations from July 2022 was that now clinics are able to store training materials, so training gametes and embryos, which allows practitioners within the lab to have availability of gametes for training and development of their skills. We're all aware that completing consent forms is a quite overwhelming process. So we want to look at how we can adapt our practice, how can we support patients to ensure that there's informed consent. So finally, finishing with a question. So how do we find the right balance between giving too much information to patients, but the necessary information for informed decisions? In terms of the future of this study, So as I said at the start, Morven Dean did present this study at Fertility 2023, and there were a few people that did reach out to her following that. So we're quite interested to look at other centres' results to see whether the trend that we've seen, whether it's specific to Dundee, is it something that we're doing here differently to other centres, or is it something that's trending across the UK? And we're keen to share practices to determine areas that can be improved. Thank you very much.
Thank you very much, George, for that presentation. And I was particularly pleased that you gave such a nice shout out to Morven at the beginning, because I was in Belfast and heard her talk, and that was one of the inspirations for actually doing this event. So thank you for that. Okay, let's go now to the final this evening, and that is Dave Wales. Dave is Quality Manager at the Edinburgh Fertility Centre, and he's Chair of the Scottish Quality Management Discussion Group. So, Dave.
Thank you, Ciara. Try saying that 5 times fast at every conference. SQMDG is probably a little bit easier, I think, even though it's still not very catchy. Sorry, so today I'm going to be talking a little bit about reducing footfall for patient and staff safety within fertility centres, and the kind of revitalisation of this Once for Scotland approach that you might be hearing about. So, if I can get my slide to move on. There we go. So, as Ciara said earlier on, when we closed the centres down in late March, early April, there was a lot of concerns about how to get it back up and running again. And despite there being a lot of guidance out there, there was no handholding, there was no kind of direct kind of how-to guide to get centres back up and running. So there's a lot to consider, and it's not working with an NHS health board as well. You're not just concerned about your staff, your patients, it's the NHS as a whole. So the things we had to consider were things like patient and staff safety primarily. So we had to introduce new cleaning regimes, so new cleaning products. Obviously going to be a challenge within a fertility centre because embryos and exposed gametes can be sensitive to certain cleaning fluids, so we have to be careful what we used, but make sure that it's obviously effective enough that it killed COVID, or at least reduce the risk of COVID getting hold in the centres. We had to use enhanced PPE, which is your face mask, your FP3, I think they were called, masks for some theatres. You also had visors and aprons as well, disposable aprons. And of course, queuing and waiting room management. So if you're attending a fertility centre up and down the country, when you arrive at that for your appointment, chances are there's a good dozen or so people there already waiting. But we had to also reduce that and limit that as much as possible, because you couldn't have people sitting shoulder to shoulder when you had social distancing. So massive challenges to overcome in the first place. But this was compounded by trying to limit exposure, that face-to-face time with patients. Because although that patient may only spend 10, 15 minutes in a room with a doctor or a nurse, that doctor or nurse is still spending time with 20, 30 patients. So to reduce that as much as we possibly could during those initial stages was highly important, as was limiting travel. As the government guidance was telling us at the time, travelling was only under, if it was essential to travel. And going to and from a hospital several times was essential for your treatment, but limiting that as much as we could was very important. Next was to do with NHS resources as a whole. So despite most fertility centres being their own little bubble, their own little kind of system, they do still pull on NHS resources. So things like equipment and consumables, like I said earlier on, with masks and aprons, all that stuff is centrally purchased and distributed across the NHS. So getting hold of enough hand sanitizer and stuff was important to try and make sure we kind of kept the service clean and kept, stay patients and staff safe. But we also had to be aware that the staff are also a resource. So within a fertility centre, if your theatre uses anaesthetist-led sedation, you need an anaesthetist, they'll need an ODP, somebody who needs to assist them. And if you need those people, you're taking them away from other aspects, other areas. So it's important that if we did need anaesthetists, we were only using them sparingly and when we needed them. And obviously being conscious of cases of what they call ovarian hyperstimulation syndrome, so OHSS. which obviously would impact the NHS as well. So the HFE actually asked us to record instances of OHSS that resulted in hospitalisation to try and work out the impact opening a fertility service would have on the NHS. And this turned out to be fairly limited, to be fair. Excuse me. And my last point there is, not point one of the more important points, is that the age of the egg provider or the intended birth mother is really closely linked to the success of treatment. So younger eggs tend to make better embryos, which tend to have better outcomes. So getting patients in when they're younger is highly important. So a delay in treatment because of COVID and having to shut down these centres could impact the success rates of those patients. And I'll come to what we had to do to try and address that in a few minutes. The next is obviously an obstetric risk for those patients who are kind of keeping into their 40s. And that's just a known risk for any mother in their 40s and 50s. And last is NHS funded entitlement to treatment. So in Scotland, you're entitled to 3 funded cycles of fresh IVF treatment and the subsequent thoughts associated with that, providing you meet the rest of the criteria. Now, age limit, there is an age limit on that criteria as well. And of course, if you're right at the cusp, if you're up at 40, 42, 45, you may be eligible 1 month, and with the centre shutting, not be eligible the next month. So how do we address these problems at a national level? We formed the ACU leads. So ACU is Assisted Conception Units. This group consisted of doctors, nurses, scientists, fertility network representation, Scottish Government, quality manager, and a business manager. So had representation from all across the field. One of the probably more important ones here is the fertility network. So in quality world, we'd call them the voice of the customer, but it really is, that's our connection to our patients. That charity allows us to hear what our patients' thoughts and feelings are regarding the service across Scotland. So this group is there to support each other to make sure we're taking a national approach to in finding solutions. So you see there, initially it's like jumping out of a plane, unaided, you're by yourself, and you're trying to find solutions. But with this group together, these are the kind of core things we looked at. So identifying and resolving challenges that came off the back of COVID and shutting down the centres, of course. Sharing best practice, so learning from each other and sharing that across all of Scotland. Public communication and patient information was a very challenging area, with the government guidelines changing very regularly as they had to cope with the developing pandemic. We too had to develop these very, very quickly, but we had to ensure they were clear and concise for our patients. It was not enough to just regurgitate or reiterate government guidelines, but to adapt them so they were more specific to what was happening in your fertility centres. Next, we had to look, well, part of this, sorry, we had to look at collaboration on projects. So things like the fertility consent platform we've already talked about. I was part of that group where we did we called it an integrated impact assessment. So looking at how this system potentially worked better than the face-to-face, the physical systems that are in place, and would that negatively impact any particular patient demographic or groups. So that was a massive project we undertook. And next, it also allowed us to work agilely. Now, unfortunately, you don't get an icon on Microsoft for agile working, so adapting to quick change, we've got a guy changing his tail. So that's as close as I could get, I'm afraid. But that was really important during those early stages, being able to adapt very quickly to what happened in government guidance and as the pandemic progressed. Because nobody knew how it was going to progress day on day, month on month, week on week. So we had to all have our finger on the pulse and all be singing from the same hymn sheet. And that allowed us to establish new processes and systems locally and share them across the services. No two services are the same, but sharing that best practice and establishing those new processes gives a little bit more comfort and a little bit more confidence. And I think it's a testament to this group and those working in the fertility centres, fertility network and the Scottish Government that we managed to get the centres open so quickly after we were initially asked to close. I believe the HFE said we could apply to reopen, as we said, in the 11th of May. I think we were open by the 19th. So we were that ready. We had everything we needed to be able to open safely. No mean feat. There we go. So Once for Scotland approach is not a new concept. It's been around for a while. But I think with COVID, it kind of forced us to act as one. We were doing that in with a lot of different projects, but because COVID closed all our centres down at one time, we then had to work together to see what would work across all of Scotland, not just within our own little bubble. So the Once for Scotland approach is generally to provide the best possible service by sharing best practice, as I said, is to ensure the same access to treatment and support, be it counselling, be it storage, and ensuring that the same treatment and storage options are available across Scotland. So even if you're up in Aberdeen, you're doing the Highlands and Islands, and people are off in various remote locations, ensuring that those patients still have the same access to those resources. And finally, consistent communication and information. Again, no mean feat when the sands are constantly shifting under your feet, but that's what we strive to do. And I think with this Once for Scotland approach, we've built a lot stronger connections between the 4 centres. And I think most of the people on this call today, I recognise names from the centres because we have got a lot closer. Oh, slide stuck again. There we go. So I'm going to very briefly talk on one of the innovations, which was Near Me. So Near Me is a little bit like Attend Anywhere. And it's also a bit like your Teams and your Zoom, but a little bit more secure. So it's an internet-based video consulting tool. It's a secure means of hosting a remote appointment. So you have a digital waiting room, you come along as a patient, and you're invited into the conversation with your doctor, your nurse, your scientist, whoever you're dealing with. One of the best things about this, being that it became a necessity during the early days of COVID, was that it gives you not just sound like being on a phone, but vision as well. As we all know, communication is great when you're face to face. You've got a lot of body language. You can use your tone. You can use, there's a lot you can use to communicate effectively. But if you're only having a phone call, it's just you don't get that personal touch. And I think that's the thing that's most important. As I think my colleagues have already spoken about, when a patient is going through a difficult time, or they have to have some difficult news, or even just if they're finding the whole experience a wee bit stressful, seeing somebody face to face, or even just having them on a screen, being able to see who you're speaking to can go a long way. And finally convenience. Now, we talked earlier on, obviously, about how sometimes you get people sitting in their pajamas, you get views of up people's noses. It doesn't necessarily mean you necessarily get the best environment for having that conversation, because it's at the patient's discretion. It's how they're contacting you, if they're using a phone, a laptop, but it's convenient for the patient. As we said before, if you are having to travel across Edinburgh in the rush hour, or from Edinburgh to Glasgow, or vice versa, it's a long way to go, and it's a lot of stress for the patient to try and organise themselves and try and organise them and their partner if they're attending with one to attend these appointments. Being able to do it at their leisure, when it's convenient for them, when they're comfortable, and when they feel more secure, can be for the best. So this is just a very brief overview of how often we've used Near Me within the service. So we are a very paper-heavy service, but we are trying to embrace the electronic, the paper light ethos. So you'll see back in April for this kind of pale blue line or green line that it wasn't even on our radar. Near Me wasn't something we used at all. A lot of our appointments are very kind of, they require patient interaction, they require face-to-face, mainly because you're getting scanned, you're getting bloods taken, a lot of things like that. So you have to be physically there. But as we've discovered over the years, since COVID, there's a lot of points you don't need to physically be here for. Sometimes it's just information, sometimes it's just that support, touching base. So from April, we introduced the system to the end of 2021. We had quite a fair few appointments in there, but most of them, as Alison and Lesley were talking about, were counselling appointments because patients were anxious about trying to get back into treatment. That continued into 21-22, but obviously a significant step up. It's worth noting this is a cumulative line, so this is increasing as the year goes on. This is going up. So in 2022, we saw that's climbed quite significantly. And in 2023, we've not quite leveled off, but we're kind of in a similar footing. We're expecting this over the next year for this to increase again as we move our nurse discussions to an electronic consultation. So although I should probably explain our nurse discussion happens after our doctor's appointment. So we'll have our doctor's appointment face-to-face, you'll have bloods taken, you'll have a consultation with your consultant, and then your nurse discussion, that's when you return your consent forms. But there will be no bloods taken or anything like that, or scans, so you do not require to come into the service itself. But that said, at the end of the day, it's all about patient choice. It's great for technology, it's great that we have this way of communicating with our patients and they have that option. But a lot of people do like that face-to-face interaction. I know that from what Ciara said earlier on, a lot of our nurses love the face-to-face interaction. But it's what works best for their patients, and a lot of our patients do prefer the face-to-face, and they don't mind commuting in to come and see us for their scans and for those appointments that don't require like a hands-on approach. But giving them that option to at least take some of the pressure off and allows them to be a bit more flexible with their work, with their own time. And from our own counsellors in-house, we've actually heard that there's been an increase, quite a significant increase in male partners showing up to elective counselling. So you have your implications counselling, which is not elective, but when you have general counselling, a lot of the time the male partner was not attending in couples. But we seen a massive increase in that when it came to remote, possibly down to convenience or possibly down to comfort, being in their own environment. So with that said, thank you very much for your time.
Thank you, George. Sorry, Dave. Oh, dear me,
Dave.
senior moment now. Can't even read when your name is there in front of me on the screen. Apologies for that. No, really interesting, and also great to have that sort of broader context of the NHS as a whole when thinking about this, and just the getting of the hand sanitizer, etc. Just those very basic things, at the beginning. I can imagine it's a sort of competition between departments for getting it. So let's go to the audience questions. Before we do, I was just going to go with a very general question for you all, and that was really whether you think that the changes on the whole that have been made, as in effect sort of forced through because of the pandemic, perhaps a bit quicker than they would have been even if they're on the horizon. Do you think they've been on the whole, positive, or a bit of a mixed bag, or more negative than positive? So we'll perhaps go around in the order that you spoke for you to answer that. So we'll go with Ashleigh first.
Sure. So I think at the start there maybe were potentially more negatives as everyone was trying to work out, with the new ways of changing how things were going to work practically. But now I think patients particularly like the opportunity to either attend, for example, their appointments in person or on video, because in Aberdeen we cover right up to Shetland and Orkney as well. So actually that's saving patients a lot of time and money as well if their appointments don't need to be in person. So I think I would say overall that the changes have been for the positive.
And Ciara?
Yeah, I think overall the benefits have outweighed the negatives, but I think with all new things come new challenges. So it's just trying to work out how to tackle the challenges, really. But I think it is better for the patients having the choice, and whether they want to come in or not, and reducing travel and things.
Alison?
I think for the counselling service, the benefits, it pushed me and Lesley to make sure that everything was digitised, everything was online. We took clients' emails and was able to pass out information, so that's a lot smoother. I think where we're at right now, where we can offer either face-to-face or online, means that we can suit the clients that we're working with.
George?
Yeah, I think overall it's been really positive, but there has been a lot of challenges, and because in terms of unveiling the online consent platform, the training that's needed for members of staff, I think to keep on top of that when there's so many changes occurring, to make sure members of staff are competent, make sure they can they've got the skills to be able to use the platform. And we've had to obviously have members of the admin team, scientists, nursing, doctors, and I think getting everyone on board was a big challenge, and it still is a challenge at times. So I think when things do get complicated with the online consents, it takes a lot to put it right. I think in terms of having the hybrid system and offering patient support face-to-face or with video consultations, I think that's really useful. So yeah, there's still challenges there, but overall positive.
And finally, Dave.
Yeah, I have to echo what everybody else said. It's been positive outcome at the end of the day, but I suppose like any new technology, when you have to, driven to these changes because it becomes essential to do so, it's hard to get people on board initially with new technology, especially when you're comfortable in what you do. Like I said before, about our nurses being very comfortable with face-to-face, and they're very personable, and that's also plays in their favour. But moving to technology and moving to remote consultations is more challenging. But like I said, like any good technology, once you've invested that time and the training into it, it pays dividends further down the road. But it's just that initial hump you have to get over to get it embedded and get it settled in your system. And once it's there, like I say, it should be a lot easier.
Yes, it's that familiarity, isn't it, with a new system. As someone who curses every time there's a big Windows update that messes with everything and all my settings, which is, in the scheme of things, very small and trivial. But yeah, I can imagine for some people that this would be particularly challenging. So I was going to go now to some of the audience questions. And this sort of relates to something that just sort of came up a bit then about sort of patient choice, etc. And so this question is, have any of the nursing, clinical or counselling teams in the centres undertaken a patient survey regarding the changes introduced to provide evidence as to how the service could or should be delivered? So I don't know whether anyone knows any works that's been carried out.
We do a patient satisfaction survey when their treatment is complete, and part of that includes how they feel about online consents. And I was going to include some of that, but I thought I probably wouldn't have time. On the whole, patients agree that the online consents are easy to access and easy to use. So there are some people who don't find it, but most of the patients do find it easy to use. I don't know if we include about online appointments in that satisfaction survey, but on the whole, patients do prefer the electronic consents and they do find them easy to use.
Anybody else got anything to share there? Alison?
Yeah, I suppose just to add, we also do a yearly patient questionnaire, so that gives patients, clients opportunities to be able to talk, and that's where some of the feedback that I put on was from the patient questionnaire. We're due to send out another one in November, so I suppose the questions made me think that maybe we do need to ask specifically whether we can add another question in asking whether patients prefer online and face-to-face, or whether they would like to have a mix of both of them.
Anybody else want to come in there? I suppose when thinking about the sort of this, as another question, which is how can patients be helped if they don't or can't use the internet at all, via phone or otherwise? Is not using the internet now the equivalent of being a homeless person? Because there's a sort of very general assumption that everyone can access, but if some people, they can only really do that in a, I don't know, in a library, if that is still a thing anymore, I'm not quite sure. This is, a sort of concern for them, for their privacy and not logging themselves in and out properly and all those sorts of things. Who wants to tackle that one first?
I'm happy to speak to that one.
Yes.
So as part of the impact assessment we did when we were onboarding the fertility consents platform, we looked at what would happen in the event that somebody was unable to access the consents electronically. And so when we were reviewing the processes we were planning to put in place, the original thought was we'd get rid of all our paperwork, we wouldn't need it again. But having done this assessment, we had discovered that it's not something you never get rid of. Paper will always be there. We can be paper light, but we can't be paperless in this industry. And it's mainly because of the legalities and the kind of the work we do. It's you have to make sure you have that evidence there at all times. And if it's not electronically stored and cryptographically sealed and all those other fancy words that mean it's safe, then the paper copy is what you need. Having that physical copy, something tangible that you can then use to, like you say, state claims as a legal parent if it comes to it. But yeah, the paperwork has to remain, at least in the short term. But as you say, not everybody has access to the internet, not everybody has access to a personal computer.
And I suppose one of the issues that Ashleigh raised at the beginning is that if English isn't your first language, then there are issues there, and then that also provides challenges of which ones you translate first according to your population,
Yeah, so
which may differ across the different areas of Scotland. So
that was actually one of the things we looked at when we were onboarding the system. So there are multiple languages available, but only on the information sheets, not necessarily in the consents. So that's where it's really tripping us up a little bit. Ideally, the consents could get translated into another language, but because the consents are the way they are, we have to kind of make sure they're completed on the English version at the moment. But it's a recommendation for the future.
Yeah, I was wondering. Yes, go on, Ciara.
I was just going to add in that our patients can choose to opt out of e-consent. So although most of them do choose to use it, some of them choose not to use it, and some of them can't use it because English isn't their first language. We do have quite a lot of patients whose English isn't their first language, and they need paper consents with an interpreter to fill out the paper consents. So they do still have that option.
And I guess, there are also people, with learning difficulties or who are unable to read, unfortunately, or, it could be they've got quite severe dyslexia, which may make the forms difficult. So I suppose there are quite a lot of challenges here that need to be tackled. But I was wondering, how long would it take a patient to complete the consent forms online? If they got everything right. I don't know if everyone can give me a bit of a ballpark timing on that, because I'm just curious and have no idea. No, everyone's looking a bit blank. Go on then, Dave.
I honestly couldn't tell you how long it takes for a patient to read through, because there's a lot of information to get through, and there's obviously informed consents. They need to take their time and make sure they're understanding what's said. But I think it's like one of those Ciara bits. I could probably get through it in about 5 minutes when I was testing the system out. So it can be done quickly, but obviously we'd encourage patients to take their time and read it, and sit with their partner and discuss some of the parts of those consent forms, because some of the answers are obvious, some of them not so much. Some of them need a bit of conversation. So sometimes up to a couple of hours is needed just to have that time to consider what your options are.
Ashleigh.
I was just going to add that I have heard from patients that it can take 3-4 hours, and I think some of the consents maybe bring up issues or hypothetical questions that couples probably haven't thought about before, so that then prompts discussion. So I've heard couples saying that it may be that they've taken it's over a couple of evenings to complete their consents once they've had the necessary discussions.
And I suppose this brings us to a question that George raised in his presentation about that balance between how much information patients need to be given, so that they're not, we don't want them to have to watch, 60 videos to fill in the consent forms, but that there needs to be something for them, and how we get that balance right. George, do you want to elaborate on that? I know your presentations are kept quite short, so it's a chance now to say your piece.
Yeah, I think that Dave made a really good point there in terms of the videos, that if a patient were to zoom through the videos, it might not take all that long to do. And as a clinic, we can see how long patients spend on each video. Sometimes the videos come with questions to ensure that they are aware of what they've been watching. And I think that it's just trying to have the correct balance, have a hybrid approach to ensure that if a patient is watching a video and has a question, then there's maybe potentially a drop-in clinic available at specific times for patients, and even having the option of I think some centres probably have patient information evenings where patients will come together and speak to professionals from potentially the nurses, doctors, scientists, and having a safe space to ask questions which sometimes they might not ask by themselves. So yeah, I think that there's a lot of information out there. Are we making sure that the patients are taking on board that information, they understand that information, and are having ample time to ask the questions to professionals?
I was wondering, Alison, does anything come up in counselling sessions about, this sort of information that they have, or have you noticed any increase in patients asking things you think, perhaps we need a video on that, or perhaps it's something that's, they're not watching properly?
It's maybe about treatment in general, but not usually about the consents specifically.
Has anybody else got any thoughts on the information that's provided, if they've spotted any gaps or things that may help? If not, we'll move on. I can't see any hands going up. So someone's asked, have the changes made at speakers clinics saved the NHS any money? Have they relieved any pressure on the staff? I know Ciara touched on this, but be interested to hear from the others as well. So interesting to hear if you think, Ashleigh, that it has saved you time in your role at all. I know it's difficult because then you just end up doing more things because but are you able to, has there been an impact?
It's difficult for me to comment because I actually came into this post in the middle of the second lockdown, so I don't know really what the system was like with the paper consents before. So it's difficult to say, but I think once you become familiar with the system, you become familiar with Near Me and with the electronic consent platform. It's actually quite easy to see. And then I was talking in my talk about quality assurance, so you're getting the system is actually picking up errors in consent forms for you, which wasn't there before. So I guess you could argue that saves time. There is some time that you have to spend before you see a couple. So before, say, an afternoon clinic, you would spend time in the morning looking through all the couple's consent forms. So I probably am not the best person to answer if there's a difference in the time spent, but maybe the time is spent in a different way rather than actually reducing the overall time.
And how about you, George, and the embryologists? Has it made any marked difference?
From our perspective, I think because the processes that we've got set up in Dundee, I find it has been quite challenging with the online consents because of the errors that can occur that patients maybe might make. And so I do, it's very interesting listening to these talks today to see, I'm actually looking at processes that's performed at other centres, and is there any way that we can improve what we currently do? But no, in terms of the time that as scientists that we spend on consents, online consents with patients, I think that's increased in comparison to when we looked at paper consents.
How about you, Alison?
Well, I think the big difference is that we are able to see more clients, but more clients are asking for a counselling service. So, yeah, so we're not saving money with the counselling service. The biggest financial cost will be the staff's wages, and yeah, we're being used more than ever.
I suppose it sort of freed up availability in a way, so which is
Yeah.
which is a benefit, I suppose.
Yeah.
Ciara, was there anything that you wanted to elaborate on from your presentation?
Just really the thing about the time, we thought it would save time because it would we thought it would half the appointment time from an hour down to 30 minutes for the full, what we call a post-screen appointment, where they take the history and explain the treatment and complete the consent forms. But that other 30 minutes is now spent doing pre-checks, reissuing consent forms if a mistake, phoning the patient to say you need to go and do this consent form, rechecking the consent form if there's another mistake, which happens quite a lot, as George probably knows, resending the consent form, and all the increased number of phone calls about the consent forms. So they definitely haven't saved time, but I think it's definitely that some of the changes have saved the NHS money. Things like I spoke about, access to study days, it's reduced travel, accommodation and things like that. So it has saved money and time some places, but maybe not others.
And Dave, as a quality manager, what's your sort of perspective on this?
I suppose my perspective is a little bit more stepped back because I'm not obviously in the clinics with the patients, but it has been a lot of time, effort and money obviously put into establishing these systems and getting the training in place. But like I said before, with new systems, it takes that initial push and little injection of money to actually get the system in place and get it working. Once you have that though, and you get more familiar with those systems, it gets a bit slicker and a bit smoother. And you can employ things like your quality management. You talk about lean systems and trying to kind of trim the fat to try and get it down to a very sleek process. So things like we're talking about there about going back and forth with patients, it sounds like it's a lot of work electronically, but if you think about how we were doing it before, where we were having to send a letter out to a patient to say, oh, can you redo this? We'll send you out the consent form again. And you're paying for that postage. And if it's something to do with storage, you're having to pay recorded delivery because you need to make sure they've had that letter and they've acknowledged they've received that letter. So when you start taking the money from that, you realise you are actually saving money at the other end. It just doesn't seem very connected at the moment. But as the system gets more slick, I think we will start to see more savings, and staff time will hopefully free up a little bit more. I don't think the appointments will get much shorter. As Ciara said, you need that prep time now to look at those consents and understand what's been said and what's been agreed to.
Yeah. Okay, I'm going to move on to another question. This one's for George first off. So if embryos and gametes aren't donated for training, we can't train tomorrow's embryologists. If embryos and gametes aren't donated for research, we can't improve IVF, understand miscarriage. Maybe these are the sorts of things that really need to be conveyed by a human in person to get across the fact that embryologists and researchers are people too, and not just tick boxes. So do you want to go with that one first?
Yeah, that's a really good point. I think that the sooner that we approach the subject about patients' wishes, if they wish to consent for training or for research, I think the sooner we do that, the better. So we aim to do that here before the online consents are issued. I think that in terms of collecting valid consent, obviously it has to be voluntary. So we want to make sure we give the patients all the information regarding training, give them a chance to ask questions, and we often find when we do that in person, then the patient can take a lot more away from that conversation rather than watching a video. I'm aware that the videos online are about 2 minutes of the video is dedicated to discussing training of gametes and embryos. So patients have 2 minutes to watch that online. I think that the face-to-face interaction with a professional is key in terms of this.
Anybody else want to come in on that? I suppose as well, actually, if you're in person there, you're in that clinical setting and it's sort of a bit more real than if you're ticking a form and you're, on your sofa or at the kitchen table or something. Okay, Ciara and then Dave.
Yeah, that was something that was part of filling in the consents in a face-to-face appointment, was you would explain why the embryologist needed the sperm and embryos for training and how it benefited the embryology service, and that it definitely wouldn't impact their treatment, and we would only ever use anything that wasn't suitable for treatment. So that was a big part of it.
Dave.
I think you're right, Ciara. That's exactly what I was going to say. I think there's a lot more connection. People have a lot more connection to their gametes and embryos than they would to like giving blood, donating, things like that. So when it comes to parting with something that they think potentially could be viable, understanding that it's not going to aid their treatment or result in having a child, communicating that effectively would probably increase the amount of people who are likely to donate. So we have the same thing with eggs and sperm donors in Scotland. Is understanding how that could benefit others, and that understanding that it is a little bit more emotional to detach yourself a little bit from these things. So it's not like, say, it's not blood, but yeah, getting that message across. Something's a face-to-face and kind of personal touch goes a long way, I think.
Yeah. And so I'm going to move on now. So someone says a couple of presentations mentioned issues with people beside the patient being in earshot online appointments. Issues of online etiquette were mentioned, but what about patient confidentiality here? How can we ensure that appointments are private when they're online? So perhaps we'll go with Ashleigh first. If you were having a video appointment with a patient, would there be any sort of process about checking that they're in the right sort of environment, I suppose?
I think there's a responsibility on both parts, probably for patients and for the clinician doing the appointment. We make patients aware what's going to be discussed. They know that it's going to be about their treatment, and we do ask that they are in a private environment. And I think I'd be very aware, if it was quite clear on the video that a patient wasn't in what should be a confidential space, they looked like they were in public somewhere, I think I would just ask to rearrange the appointment. But I think it's probably just maybe making it clear, we send out information on what a near me video consultation is, and probably just making it clear in that patient information that that sensitive information will be discussed, and it's important that they are in a private environment.
Alison.
Yeah, so I suppose we can only do what we can from our point of view. Again, it's I would also agree that it's the client's responsibility that they feel that they're in a private space and a confidential space to be able to talk. We do what we can by sending out our counselling agreement, the online etiquette beforehand, and then our counselling agreement we would go through in our initial appointment and cover things like privacy and online security and confidentiality.
Yeah, because it's obvious they're joining you and they're sitting on a bus or something. Then I can imagine. Well, it's not also a very satisfactory experience for you as a professional, for anyone on the panel as a professional, dealing with someone like that, because it sort of makes everything quite a challenge. Ciara, I didn't know whether you wanted to come in on this or not.
Yeah, all I was thinking was the nurses' appointments are all carried out in the clinic, so the nurses don't work from home and haven't done. So from that point of view, that's not an issue with confidentiality. But I have taken a wee note of your information about online etiquette that you send out, Alison. That would be quite good to look at and see if we could maybe include that in the information that we're sending out to patients about their online appointments, to see if that would help.
Yeah, because it's one thing people not being perhaps dressed as you'd like, but it's quite another when they're in obviously a very distracting environment, isn't it? Okay. So I'm just trying to see. I think we've asked that one in different guise already. So this is a very general question, really, for all of you, I think. So, what do you think would happen if there were another similar pandemic? Heaven forbid. Are you pandemic ready? Do you think it would spark yet more innovation? And I guess, what do you think? They don't ask this bit, but I will. What do you think that innovation may be? So let's go to Dave first, with all his committee work that he did and his skydivers with Arnie's head stuck on.
Oh, innovation. It definitely gave me more grey hair. That's for sure. That was a very tense time. But it was one of those scenarios where you're pushed out of a plane, you have no support structure. You had to then develop something very quickly on the fly. And so thank goodness we had the other services and other centres to hold on to and try and work together. I think if we had another pandemic and it went into a kind of lockdown-based scenario again, I think the infrastructure is there to be able to keep the premises open and safe. But it would be very challenging again, because I think we are still very face-to-face focused. So in the clinics, although we do have near me, we do have other ways of communicating with our patients, there's still those scans, there's still those blood tests need to be taken throughout the course of treatment. And that's where it was really challenging. Not only that, but I suppose I think it was Ciara that was mentioning about the swabbing before egg collection, which is, again, it's one of those things you've booked appointment slot, you've got your anaesthetist there ready to go, then you can't take the patient because it's not safe. So things like that, I mean, I don't know how you can be better prepared for things like that. And a lot of it is in the hands of the wider public as well. So being sensible, being safe, I think went from being a lot, but not as good as we could be at the start, dating quite good in the middle, and then kind of like easing off again towards the end. And I suppose it's if we, as a nation and as as an organisation, the NHS, are sensible in our approach and we are following those guidelines, I think we are fairly well equipped to be able to at least keep the service going and keep patients trickling through, albeit probably at a much lower level, lower volume.
And who wants to come in next? Ciara.
I remember seeing quite a few times during it all, when we were trying to work out what we were doing and trying to get patients back in the door and how we were going to do it safely. And we don't have a book to tell us how to do this. Nobody's ever done this before in this situation. We don't have guidelines or policies to tell us how to do this, so we have to just kind of not make it up as we go along, but kind of that's what was happening. So I think now we do have those policies and protocols, we do have guidelines, we're a lot more knowledgeable. So I think if it did happen again, God forbid, we would be more ready to act quicker and hopefully not have to close down the unit the way we did the first time.
Ashleigh.
I think I would just echo what's probably been said already. With all the SOPs that are in place, everything's constantly being updated. I would like to think that, as Dave was saying, a lot of the processes are probably already in place. Depends on the type of pandemic as well, I suppose, which no one can predict.
Anybody else want to come on that? But no one's sort of touched yet on whether they think it might spark any other innovation and what that new thing may be. Anybody got any ideas for what could come next? Not, it doesn't have to be a negative, because of a pandemic, but just something that would streamline processes. Dave.
I'm going to be a typical quality manager and say streamlining, because I think as the pressure builds up, we need to find better ways and more efficient ways of doing it. If we're too comfortable, we don't need to innovate. But as soon as that pressure's on, we have to find ways to save on resources and so on. So I think you're leaning Six Sigma stuff, quality management speak, but it's all that stuff is really useful and it becomes more important, I suppose, during times when we're under a lot of pressure.